Dr. Christine Phillips, I'd like to welcome you up. We're very privileged to have Dr. Christine Phillips here today, who is an Associate Professor at the Medical School at the Australian National University, ANU. She is also a GP at Companion House, a torture and trauma service in the ACT, and is the current chair for the Refugee Health Network of Australia, also known as REANA. So we understand that you've got some perspective of the NDIS, and we look forward to hearing your views, having experienced this already.
Have you got my presentation?
Yes,
you do. You can hear me at the back. I happened to be in the in Queensland and was asked to give this talk. And at first I thought, I don't know anything about the NDIS. And then I realised that I actually filled out 3 access forms that day. The NDIS has actually been in the ACT for 2.5 years. So we've had quite a lot of experience with putting people onto the NDIS and consequently with the way the NDIS actually impacts upon people's lives. So what I wanted to talk today about is the 3 phases so far of the NDIS in the ACT. Then again, your issue at the moment is accessing. So I'll talk about people with refugee backgrounds and their NDIS application. And then the planning issue, troubleshooting for your patient, and some of the learnings for that I hope you can take from the experience in the ACT, at least, of things that are not good things to do in relation to the NDIS. I think we can start by saying the NDIS is a fabulous opportunity and that everything about the NDIS is something that we would like to support so that it becomes as strong as possible. The NDIS started off in the ACT in the late 2015 and we were one of the pilot sites. And so from our perspective, that we got to see the NDIS at its very best and it was fantastic. So when the NDIS started with us, there was excellent planning, there was a lot of brilliant, innovative ideas from the planners working with refugee clients or any clients, and there was a lot of focus on patients' needs. What would they need to be able to fully engage and live their lives as fully as possible? We had specific funding at Companion House, and Woonunga, which is the Aboriginal Community Controlled Service, also had specific funding in order to engage our clientele very early on in the planning process. And as a consequence, those clients of both those services actually were engaged very early in the NDIS. So at that stage, it was really exciting. Then we went through the early establishment stage, and at that point there was a kind of a trial by fire for providers of services. They were either actually going to be able to provide services that were funded through the NDIS, or they would turn out to be not very good at all. And there was a lot of startups that emerged, startup agencies delivering services that emerged in the ACT at that stage, and some of them collapsed. And there were emerging gaps that appeared in service delivery in the ACT, particularly because of a decision by the ACT government to stop funding their own service providers of allied health services. So there was this gap that had emerged, and clearly the thinking had been that the NDIS would take up that gap, and of course it didn't completely. The assessment processes started to slow, and increasingly a situation where in fact the applicant had to prove that they were a good candidate started to emerge, whereas previously there had been a lot of willingness to actually accept the levels of disability. So in the early days we did not write, I don't think, very good forms, and it was enough for the person to actually come in there with their disability obvious for the planners to actually start to plan around that. The third stage is now the program's gone national, and it's gone national as it was not unexpected. There are now funding gaps, there are overstretched the capacity of planners, and I think the NDIS stands or fails on the quality of its planners, and currently that is an under-resourced facility, and so with the absence of good planners, and I'm sure that's going to improve, but at the moment the planners do not have the complexity of thought that clearly the small group that we had at the beginning did. We're starting to see the consequences of local gaps in our region of the lack of allied health services and the collapse of some provider groups. That some of those startups have actually collapsed. Now, this is not the final stage. This is just a transitional stage, and I'm sure that it will improve, but that is where we are at the moment. And I think you are sort of here in relation to where we are. It would have been great if you were back where we were in one, but there was a lot of money then. And so now that you're starting, you're in this position. So if we start to talk about people with refugee backgrounds and the NDIS, that's a picture from Handicap International, just to remind us that in the past, disabled refugees really were not a huge component of the resettlement process, and that has certainly changed some time ago, and we know that with the ongoing intake from Syria, that they are a very disabled group. So we are now dealing with disability, even in newly arrived refugees, in a way that we didn't used to. So there are 3 steps, and these have been outlined, but just for your purpose, we'll go through them again. Step 1 is that you have to get enrolled. So you have to get the form, and the client has to apply, or hopefully you can, and you will need to help them fill out the form. Now, as has just been pointed out, you may need to help them apply, but the client has to apply. I used to think when I started this off that it would be like DSP and I could get the form online, or that they could go down to somewhere like Centrelink and come back with the form. It was astonishing to me that they actually had to apply and get the form and come in with it, whereas every other form for any kind of process of this kind, the person could access themselves quite easily at a Centrelink outlet. And it seems really odd to me that the registration process is completely separate to the getting the form. Nevertheless, there it is. You won't get the form until you actually apply. So that complicated process of applying is being brought in, and I trust that at some stage in the future, the forms will be available at Centrelink. They're not at the moment. Then you have to document the disability. It's really important in writing this up that you focus on the disability and not the disease. You can't say that this person, even if this person has really terrible osteoarthritis or terrible something that is quite disabling, you have to focus on the disability, not the fact that they've got a medical condition. If you just write down a medical condition, and I assume that if you're doing it for refugees, you'll be writing all of this out yourself. If you just write the medical condition, then it will be set aside as a medical problem that the health system should look after. You should include as much documentation as you can, including letters from specialists and documenting the disability. The NDIS is really big on having standardised tools, and Jen just talked about all of those tools. If you've seen your paper, you'll see in section F there's a whole lot of potential tools. Now, most of us never use those tools and have got no experience with using those tools, but it's really handy when you put in your access application if you've located one of those forms and filled them in. So I would strongly encourage you to fill out a standardised form. That is a piece of strategic action on your part, because most of those forms have never been validated for this population. Nevertheless, it seems with the planners, and given that we're working with an overstretched resource, if you turn up with a validated tool, even if it's not been validated to this population, it's useful. And you don't have to use those tools. So I recently wrote out a form for somebody with sickle cell disease who was very, very disabled. Now she has, as people with sickle cell do, a relapsing disorder. So she could go to school some days, and then some days she couldn't go to school because she was in intense pain and had to go to hospital. And all of the time she was very, very fatigued. In fact, fatigue was her dominant disability and stopped her from doing everything. And with some support, she would have been able to engage. She really needed support to be able to go to school, and for the school to recognise and have ways around her being on and off all the time. But so I found a tool online that measures, it was a standardised tool for fatigue, and I filled it all out with her in great detail and then said, here is the standardised tool for fatigue. Because I thought, since that's her disability and since standardised tools help, that's what I will do. And that was actually successful. You need to consider what the patient needs, has been completely discussed, and consider with them what they think. I think this is a good time to have that discussion. What do they think they would need to participate fully in the social world? This seems a little bit big and overwhelming and like a very, very long consultation, but you can probably get a sense of it. You can start to run through some of those things quite quickly. Would you would you actually like to be able to learn to drive a car? I know you can't drive a car because of your disability. Would that be a useful thing for you to be able to do so you could live more fully? So you can actually, you can help them to actually think more broadly and fully about those sorts of things. And I often will document that down on the plan, because they take the plan to the planner, and if somebody's written a car might be, driving lessons might be useful in order for them to access, then they can hang on to that. You should be specific and clear, and don't write about their medical treatments. They don't need, you will not get anywhere if you say they need help to be able to go to their doctor's appointments, even if that's what the patient really says that they want you to help them to do. That is not under the auspices of the NDIS. Step 2, get a plan. The plan is done with a planner, and this will determine how much money the person will have and the purposes for which that money will be spent. The person can administer their own funds or have them administered for them by the NDIA. And generally, we have found in the ACT that the NDIA has ended up administering the funds for refugee patients. Not always, but generally that's what's happened. I can't recommend strongly enough that a support person should go with the person to the planning meeting. They should not go by themselves, even if an interpreter has been organised and the support person isn't the interpreter, that a support person goes with them to help to try to think more clearly and broadly about what they will need. Step 3, use the plan. Now, this is a bit beyond yours. As Jen has pointed out, if the funds to the plan aren't used, they can't be rolled over. Well, they won't be, if they're not in the ACT. And next year's plans will be reduced because it's been assumed. You said you wanted so many thousands for counselling and you haven't used any of that, so therefore you can't really use it. It is difficult to incorporate fluctuating or emergent disability into a plan, and I hope as the NDIS becomes more part of our way of thinking, that these fluctuating disabilities, and sickle cell, I think that's a good example of a fluctuating disability, incorporating that into a plan will be useful. It means that when you're thinking about your plan, you're doing your planning stage, you actually have to constantly think, what is life? What would you need on your worst day? Not what do you need on your best day? And of course, that's a bit like the DSP. People actually don't can feel a bit disabled themselves. And there's an argument that the NDIS is actually a disabling process in itself because people have to focus on all of the things they can't do. Patients can generally, they change providers of care, but we haven't found that they can change the planner in the ACT. So if the planner has actually given them a very narrow plan, you can't go back and say later, I just want a different planner. You've stuck with that plan. That's the plan they've got. So they have to, hopefully the important meeting is the one they have with the planner. Special considerations for refugees. Let's go back to that one. As we've said, systems for facilitated access requests are poor, and this is a complex process to get access to, and the fact that registration, which is what you're doing when you're ringing up, you're basically just registering, the fact that that is the process that you need to do to get the form is stupid, but that's the way that it is. It's stupid and unfair and inequitable. Whereas if you'd separated that, you could actually easily, I think, register separately and then get the form and start that process. Now this stage is documents, documents, documents. And you may find that you need to prove what is an obvious disability. So we have had to send people who are deaf and have been deaf since the age of 3 and who cannot speak to Australian Hearing Services in order to get an audiogram to prove that they're deaf. It's no good. It hasn't been enough to say that they are deaf. There is no Australian document. It's quite racist, isn't it? There's no Australian document to prove that they're deaf, so therefore we have to have a document to prove it. And the documents, although it says a letter from a GP can be incorporated, you're much better off incorporating a letter for a specialist. Now that is complicated when it's a newly arrived refugee and their data is actually from another country. It's especially complicated at the moment because we're not actually getting the data from the previous assessment, but that's a separate issue. one problem at a time, and that problem's being sorted. But it is a problem when the information that the person comes with is from the Italian hospital in Beirut. That may not be considered by the planner. Good as that hospital actually is, that may not be considered a reasonable proof that the person has cerebral palsy. Now, I don't know what your wait times to see specialists are in Brisbane, but they are inordinately long in Canberra. So proving an evident disability has actually been a delay for us in accessing NDIS, and that's particularly problematic in a jurisdiction that has actually stopped its allied health services provision, state-funded allied health services. Although it's a nuisance to fill out a tool, it may well be worth your doing it because it will bump out and make it look like there's more packages of information supporting the level of disability. And then considering what the patient needs, don't write something that the settlement organisation should do, like AMEP. Think really broadly. Now, your patient may well say, I just want to go to good English classes and I just want to have these things. But if in fact you know that that's what the settlement service should be doing, think of something more broadly that is actually going to be useful for that patient. And so that's, as we've heard, that's actually a discussion to be had about aspirations, and that may be a really new discussion to have. Step 2, now the planner probably will have little experience of refugee health. Now that is significant because particularly in this field, there's a lot of interplay between trauma and the disability itself. So if they're not experienced with that kind of interplay, that may be problematic, and that really is why somebody should go with them as well. The person has to, the needs as stated by the person need to be what they really could benefit from, and again, as we've just heard, that is a bit that requires thinking more broadly about how their lives could be expanded. In our experience, the administrator is almost always the NDIA, but it can be the person themselves. There's quite a compliance burden with actually holding it yourself. So, whereas if the NDIA holds it, there's a different kind of burden, and that's actually accessing the NDIA and discussing that as well. So there are two burdens either way we're finding at the moment. We didn't used to find that, but we're finding it now. Now, this is wrong. When I first set this up, we actually used to have to ask for interpreters as part of the budget, and that's no longer the case. So just ignore that. Ensure that they know that they can actually access interpreters through the NDIA. Step 3, use the plan. The settlement needs may in fact delay accessing disability support, even in the plan, and that can be problematic. So it's important, I think, once they've got the plan, that you encourage them to use it. Especially if you've been trying to think broadly about this. NDIS seems to work much better with a stable disability, and the ideal NDIS patient does have a stable disability, I think, like a limb amputation, but most disabilities aren't stable. And the NDIS the chosen providers that are registered with the NDIA, we have found in the ACT may be inadequate or inaccessible, and that doesn't seem to be considered, the transport or the difficulties of getting there. And that reflects, that's a recent finding, and it reflects the rollout of the system, and I'm hoping that will change too. Abandonment of providers by clients is something that we are now seeing in the third phase, our third phase of the program. I just put that picture, that moving picture of somebody about to go into war to make the point that trauma, war soldiers do receive support for their psychosocial disability through Vets Affairs. But the survivors of wars in other countries, they will need to have their supports covered through the NDIS. And if you take one thing back from this meeting, take psychosocial disability. So the NDIS will cover psychosocial disability, and that actually refers to the kinds of trauma that many of our clients may have, which compounds some of their other disabilities. So when you're writing up their disability and they are very traumatised, use the word psychosocial disability and look up in the WHO what that actually means. Sorry I haven't written that up here, that's because I was writing this without an internet connection. But that would be my one take-home message for refugees, is know about what psychosocial disability is. This is my point on abandoning clients. It's a true story. This is not her name or where she comes from. She was a 56-year-old blind woman from West Africa, and she had received funding through the NDIS for a suite of services, and those funds were administered by the planner. So she was blind and she had a disability in terms of movement as well. And one day she came into our service with her blind stick and limped in with a letter written in English. And this letter said, "Dear client of the organisation, which I will not name, we are writing to tell you that we have undertaken a review of our clients and have decided that we are unable to meet your needs within our current financial arrangements. Please find enclosed a list of other services that can provide care for you," etc. So she was let go by her service provider a year and a half into them providing, or a year into them providing services. It mustn't have been a year, must have been less than that, but she was actually let go because they had they'd gone through their finances and realised that they could no longer look after her. So they sent a letter in English to a woman whom they should have known was in receipt of NDIS because she was blind. In any case, she didn't speak English. So this reflects the collapsing of some of the new services that were set up. So a lot of services that are kind of interested in actually delivering services. What was interesting about, in this case, when the service collapsed, the people they let go were refugees. Not because they were more complicated, because I think they were less likely to make a fuss. So there are inequities in this system, and I think that kind of, the fly-by-night providers will emerge everywhere, and this was a fly-by-night emerger that actually just abandoned their clients. So that was shocking to me that somebody could do that, and it spoke something. It spoke to the lack of a service awareness of some of the agencies. You wouldn't actually find an outpatients department. They might effectively do something like this, but they never actually write to you and say, "We're going to let you go because you cost too much," which is really what happened here. Now, we were able, in fact, to actually to connect her up with a new startup agency, and I'll talk a little bit about that because there are some of the agencies that are starting up now actually are NDIS ready and aware, and there are new opportunities for refugees working in this area. So she's now connected with a service that is run by a migrant woman who actually employs refugees with health service backgrounds as carers. So it's a much better system. But in the meantime, she hadn't actually come in with her letter saying, "What does this say?" She potentially would have just had nothing. So troubleshooting for the NDIS, these are my 3 troubleshooting points. First of all, my patient isn't actually enrolled for the NDIS. So you'll find we had a pretty good rollout, but still I'm finding people in the community who actually never got picked up. You'll find it sometimes through look-back processes, or somebody will come in and you'll realise there's your patient Maria who actually has cerebral palsy that somehow she hasn't been to see a doctor for a long time and everyone had forgotten that Maria has cerebral palsy. So she needs to be enrolled for the NDIS. And the ACT, she especially needs to be enrolled for the NDIS because there's no other way for her to access any kind of allied health support. So this is difficult, I think, to do the whole thing in general practice, unless once you've got more slick at doing the forms, you'll be. It's not always as complicated as it sounds right now. You do get slicker at working out the forms. But in your own general practice, a practice nurse can actually do it as part of a care plan or often part of a health assessment. If the person's got intellectual disabilities, a lot of things where you could actually create a health assessment around them. Specialised services often have staff who will help patients enrol in the NDIS. So in the example in the ACT, the mental health system has staff whose role it is to enrol patients in the NDIS, and you will have organisations in here whose role, the LACs I suppose are the people who are supposed to be doing that. And there are local advocacy groups, and we've just heard from one of them, and Deaf Advocacy is actually a really good group for us in the ACT. And your primary health network should have a list of services that do this. You should be able to readily access who can help with the advocacy to get somebody enrolled. Currently, getting somebody enrolled is a bit complicated because of the connection and the ways the phones, going first through phones. You should be able to do it online, and you should be able to get the paperwork down the street, you know, in the newsagents, like with everything else. Second point, your person has applied and they've just got their letter that says it's been rejected. So it's useful to find out why they've been rejected, and they should tell you why they've been rejected. They may be rejected because the planner or the assessor thought that they had a medical illness, and therefore that medical illness or a temporary illness, a temporary disability. And now if that's correct, then they don't actually qualify for the NDIS. But if they have a medical illness and associated with that is actually disability, then you need to demonstrate the impact of that illness on their disability. If they say the person isn't disabled, then you may need to actually demonstrate disability. And you can reapply and you can appeal to the AAT. The appealing to the AAT sounds like a big job, but actually it's quite successful with psychosocial disability. Of all of the appeals, many of those are overturned. And many of our patients psychosocial disability will feature. So one of the things one of the reasons it may have rejected relates to inability to understand psychosocial disability and the interaction between a range of disabilities. And the AAT will get that. Hopefully you don't have to go that far. Hopefully at the appeal stage somebody has also realised it. But I would encourage you, if you think that psychosocial disability is an issue, to actually put that on the original access form that you write. What happens if you're like my patient that I just described and the caregiver disappears? So the manager, the care manager, the planner, whoever's managing that person has to, the money will have to negotiate a new provider. And if not, they can't. This is the opportunity for a new one to be negotiated for the patient. And in Queensland, that may well be the LAC that might be helping with that. I would strongly encourage, I wouldn't encourage a general practitioner or a busy GP to actually get down to trying to negotiate a new caregiver, because it's really complicated. I'd be trying to use your networks, and here your networks will be when they're up and running, the LACs. If you were going to learn from our state, what would you do? Well, you would keep your publicly funded allied health resource. You wouldn't get rid of it. The NDIS is never going to cover all disabled patients. It's not going to cover asylum seekers. It's not going to cover people who are not yet fully diagnosed, and many disabilities, just like many illnesses, exist in a kind of a netherland where they don't have a name on them. So one of the things is to find somebody who will put a name on it so it's fully diagnosed. People who are waiting assessment, people who are disabled but have been rejected through the process, and these may include, we have found that people who are about 64 or 63 will almost never get onto the NDIS. They will be rejected and they will have to wait for the pension to come in practice. I heard what you just said, but in practice what we've actually found is if you're a certain age, probably what's going to happen is it's just going to be deferred. Decision making will be deferred until you turn out to be 65. Of course, that's never written down. Those people who are disabled but might be awaiting surgery that might be curative but are going to be actually waiting for 3 or 4 years to get that surgery, another group that don't actually meet the NDIS. And what we're finding is, in the absence of actually, for us, publicly funded allied health services, we're finding this re-emergence of charity ad hoc coalitions around individual service needs, which is exhausting. That you have an asylum seeker with cerebral palsy, that you actually have to get the Cerebral Palsy Alliance and the person who's from the Catholic Church to come in and try and find money for that individual person, when in fact they have a right to those, and in the past the state used to actually have the service that would provide those. My second statement from another state is that you should monitor the care providers. This is the wild west of care provision, I think. There are many start-up companies offering care, and refugees are vulnerable to exploitation in these companies. But there are opportunities for skilled refugees to open their own care provision services, and that's what we're starting to see. People, the NDIS has been around for long enough for the people who are nurses or who are physios from their own country who aren't registered here or who've started that training to actually start to form companies, little organisations where they themselves are offering those services. So I haven't heard that happening in other states, but we're really starting to see this emergence of small businesses from people of refugee backgrounds. And that's really exciting, I think, because historically they have been cut out from being able to engage with their professional backgrounds. And this is may represent a new route into people being able to reconnect with the professional background they had before they came out to Australia. The other problem we have is with the early intervention services for children, which were presented here. The early intervention programs for children may be a bit too limited compared with what is provided by the state. And I think state services should maintain drop-in support groups. We have no drop-in support groups, so we don't have speech therapy for kids who are not disabled in any other way, but they have a speech therapy or a speech delay, that kind of service provision that used to have drop-in people for. So we've lost that, so we're having to negotiate with the University of Canberra's speech pathology department to see if they will again do some charity provision. So the NDIS, strangely enough, is actually fuelling charity provision for a group of disabled people who do not fit their, isn't that ironic, do not fit their requirements. And that isn't the fault of the NDIS, that's actually the fault of a state decision to actually defund a set of services. So we would like all of us, I'm sure, to support the NDIS to succeed. And in doing that, I think we need to be a critical friend. Former Prime Minister once said that's what we should be in relation to China, be a critical friend. We should be clear and careful and expansive in applications, and if we don't have documentation of disabilities, we should strategically build up that documentation. I don't know, it's going to seem stupid for your deaf patient that they have to go off and have audiometry, but nevertheless, there it is. We should expect the primary health networks to take on advocacy and maintain up-to-date pathways, which would include at least who the current care providers are, and they should develop and disseminate, or somebody needs to develop and disseminate, and I think they're a good place to do it, quality measures for care providers. At present, it's impossible to actually say who's a good one, who's a bad one, who's going to collapse, who's not. And there should be an up-to-date register of services that will support someone to enrol in the NDIS, and I see that's happening here with the LACs. And we should encourage local settlement agencies to enrol eligible new arrivals in the NDIS, and that should be a KPI for them, that they have done that. So if access to the NDIS is really about advancing and supporting one's life opportunities, it actually is the responsibility of the community. It's not just the responsibility of primary health care. We should be careful that this doesn't get devolved down to GPs and then set GPs up as the people who have failed this. This is actually a community responsibility, and the community needs to be engaged in this. And that's the end. Thank you.